Complications of increased intracranial pressure. Antidiuretic hormone, ADH. So to understand SIADH and DI, you must know the purpose of ADH. And each one of those plays a role in ADH dysregulation, okay? Each condition is related to the secretion of ADH. It's also called vasopressin, okay? And ADH plays a major role in how the body retains water, okay? Each condition presents oppositely of each other as well. So SIADH, the patient retains water, versus DI, where the patient loses water. So just remember that they are opposites, okay? And again, ADH is, again, vasopressin, if you want to look at it that way. It is a hormone made from the hypothalamus and stored or released from the pituitary. If there is increased intracranial pressure, it can impair either gland, okay? So it's a syndrome of inappropriate antidiuretic hormone called SIADH. And again, it has high levels of ADH. And if anything you can take away from this, the key point is that it is high levels of ADH, okay? And that equals low urine output. And that means it's more concentrated and sticky, okay? Diabetes insipidus, or DI, it's low levels of ADH. And the key point of that is it's a low level of ADH, okay? And that's an excess. You're going to see an excess of urinary output. It's very diluted, mainly composed of water. So, syndrome of inappropriate antidiuretic hormone, SIADH. The body is literally holding on to the ADH. So there's no diuresis, there's no peeing. And whatever little pee is there, it's going to be very concentrated and even sticky. And just to kind of get an idea, all of the concentration is in the cells of the brain, okay, not in the intravascular. That's where it gets tricky. So there's very little sodium in that intravascular or the blood. And that's why you're going to see hyponatremia. And it's going to be very diluted. And I really kind of like how this is summed up here. Soaked inside. SI. This soaked inside from all that ADH. It keeps fluid in the body and not the potty. That is really cute. So, or you can SI like C in Spanish. Yes, ADH. Okay. And there are 7 S's where you stop urinating. That's where that decreased urine output comes from. The second S, sticky and thick urine. You get that increased specific gravity. The SI, soaked inside. So it's low and liquidy labs. Hypoosmolality, hyponatremia. And again, that's where there's very little sodium in that intravascular space, okay? And with sodium that's low, there's going to be early signs of headache, as well as confusion and agitation, all right? And another one is seizure. So that's where you're going to have that low sodium, again, that causes seizures. That headache, confusion from that cerebral edema, severely elevated BP. So urination has stopped, swelling inside, so that's more pressure. You're holding on to all that fluid, okay? And that ADH, it also, not only is it holding on to fluid, it's also constricting the blood vessels, okay? And then 7, so you would stop off fluids, except you would give them that hypertonic, that 3% normal saline solution. You can give them salt and diuretics. So just with the number 7, think of why you would give a hypertonic solution like that 3% normal saline. Now just think about where sodium is in relation to the intravascular space and the brain cells, okay? So knowing how water moves from a low concentration to high concentration. So you put a hypertonic solution in that vasculature, in the veins, in that blood, And the goal is you want to pull water out of the cells. Then why diuretics? Well, now you have water shifting back into that intravascular and you need to get rid of it. And so the kidneys can go ahead and do their job and filter it out. Okay. And just a summary of the signs and symptoms. So, fluid overload. You can see weight gain, hypertension. And with hypertension, remember there is a high volume of fluid, of blood. And ADH is constricting those blood vessels as well. Okay. And I know with, you would think, well, fluid and sodium love each other. Well, it is a lot of fluid, okay? And ADH only works on fluid. I like to think of aldosterone loves sodium. So if RAS was involved, that's why it would be different. But in this case, it is very diluted and just watered down. So that's why you're going to see that hyponatremia. Confusion just from those brain cells swelling, okay? That's where that shift is all that fluid is in the brain cells. It's not in that intravascular, okay? And then seizures, especially as sodium gets down past, 115, that's really low. And just remember, 135 to 145 is the normal, okay? Anorexia, just think about that too. We didn't really go over it in lecture, but you're full of water, but they will also be thirsty too. Okay. And then again, all that fluid retention, just holding on, that anti-diuretic hormone. It is holding it on, so you have low urine output. Whatever urine output you do have, it's very concentrated. And you're going to see those high urine specific gravity, okay? So some nursing management of SIADH. So we're going to want to weigh them daily, okay? And then we're going to want to get strict I's and O's and mainly put them on fluid restrictions, okay? Because you keep giving them more fluid and it's just going to shift to that high concentration in those blood cells or those brain cells, okay? So we're going to restrict their fluids. And with that, we're going to have safety concerns. They're going to be at high risk for falls. They're going to have confusion from those brain cells that are getting swollen and that low sodium, which brings me to seizure precautions as well. You want to pad the side rails. You want to have a working suction kit nearby and a yonker at the bedside, okay? And for drug management of SIADH, like I said, hypertonic IV solutions like that 3% normal saline, we want to pull that water out of the cells and back into the intravascular. That goal is to have them pee it out. But we really got to be careful because they can go into fluid volume overload. I know they're already in it, but because we have to shift it out to where it needs to be, then we have to get it out. There's so much swelling in those brains. Okay, and then that's why it leads me to diuretics. Because of that hypertonic solution, that shifting, and that risk of that fluid volume overload, we're going to probably put them on like a loop diuretic. Our goal is to get them to pee all that out. And with loop diuretics, we're going to watch for hypokalemia. They're going to be at risk for that. So fluid volume deficits, fluid volume overload, that is a huge concept along with electrolytes, okay? And we just got to be careful to keep it balanced, not go from one extreme to the other. Diabetes insipidus, remember it's not related to diabetes mellitus at all. I want to say I read somewhere that it was named that because it was mistakenly thought to be part of like diabetes or something. Anyhow, so I think this is a cute way to remember it. DI, dry inside. D for dehydrated. I, increased urinary output, like liters, like an elephant amounts of pee. And again, like the 7 S's, you get the 7 D's. Diuresis, drain, high urine output. So you're just going. And with all that water, they're going to have dilution, okay? So it's going to be low specific gravity, all right? Dry inside, high and dry. Labs, they're going to have hyperosmolality and hypernatremia. So over 145, they're going to be really dehydrated. So again, there's that low fluid volumes. They're just peeing it out, so it's more concentrated. There, okay? They're going to want to drink a lot, okay? And then dehydrated. You're going to see the mucous membranes that are really dry. Poor skin turgor. Decreased blood pressure, okay? So just think about that for a minute. Why would there be hypotension? Well, there's low volume. And then that ADH, it also, there's not much, it dilates, okay? And then there's a drug called desmopressin, vasopressin. It's a man-made ADH. It will decrease urine output, increase blood pressure. So it's pressing on the veins. Okay. So summary of signs and symptoms of DI. Okay. So that polyuria, that's where they're going to the bathroom a lot. I mean, urinary output can be up to 4 liters a day. And just think about it. If we're supposed to only urinate 30 milliliters per hour, I mean, that's amazingly amount of urine coming out. Polydipsia. The body is trying to keep water and it's thirsty. The cells are still thirsty. It can't hold on to it. And again, that dry mucous membranes, that dry skin, poor turgor. I know it's very repetitive, but it's essential that, if you keep talking about it, you'll get it. Or listening to it, you'll get it. Urine's going to be diluted and that low urine specific gravity. So there's just so much in that pee that's just water, okay? Hypotension, because you're peeing it out. So with hypotension, just remember those blood vessels are going to be dilated and there's just low volume. It's getting peed out. And extreme fatigue and muscle pain and even weakness, you'll see that as well. People that are dehydrated are typically like that. And again, hypernatremia. So there's more sodium in the body just because of those low water levels. All right. And some nursing and drug management of DI, I combine them together. So we're going to want to do strict I's and O's. We're going to want to do daily weights on these people. If they keep losing weight, we know that they're just peeing out excessively, Safety precautions, just risk for falls from that hypotension. Restrict foods that promote diuresis, so we don't want them to eat a lot of watermelon, grapes, berries, caffeine, and teas. Just think about how much coffee you can drink, and I have to pee all the time. And we want to monitor their electrolytes. So remember, they're going to be hypernatremic. And just the flip side of hypernatremia is potassium. Their potassium will be low. So we're going to have to pay attention to that very carefully. And the medication typically that we'll give for them is desmopressin. I didn't mean to put pressin, but desmopressin, it's a synthetic form of vasopressin. But the side effects is hyponatremia or water intoxication. Okay. And I kind of like this comparison. So with SIADH, you're going to have low urine output. Remember, they're holding on to that. DI, high urine output, just the opposite. SIDH, high levels of ADH. They're holding on to it. DI, low levels of ADH, so they're just peeing like crazy. SIDH, hyponatremia, okay? So this just so over diluted with water that the sodium is just diluted. It doesn't seem like there's much. With DI, they're dehydrated, okay? So they're going to have less volume, and so that sodium is going to be more concentrated. SIDH, they're going to be overhydrated, okay? And that's why you're going to see these hyponatremias. These two go together, along with the dehydrated for DI. They're going to have hypernatremia. And again, that's because that fluid volume deficit. And then over here with SIADH, fluid volume overload. Okay. And both of them, however, they're going to have increased thirsty. They'll have that polydipsia. So they're going to just be constantly thirsty. Okay. Another complication of increased intracranial pressure is herniation. I know I already covered this in ICP PowerPoint, but I really want to go over it because it's absolutely crucial. And so as you can see, it's from limited blood to the brain because of some form of increased cranial pressure. Okay, the brain is getting squeezed, it's getting squished, it's getting deprived of oxygen, so it gets ischemic. And the body is trying to compensate. It's saying, hey, it needs more oxygen, let's send more blood. So you're getting more swelling, more edema. And if it goes untreated for so long, that brain is going to eventually herniate or get displaced, as you can see. And displacement, that can cause a lot of the vital areas to get pressed up against. I mean, just look at down here. I mean, this is your brain stem, and it's getting clamped down by the cerebellum. And these are major areas that control and regulate your breathing. So this is really, really bad. This is late in the game. When this happens, this is death, okay? So just think of this as a cascade, all right? And speaking of cascade, I'm going to go into more detail of herniation just because it's so important, all right? So you have an increased volume of whether it's cerebrospinal fluid, blood, or actual brain tissue that's caused by whatever, a mass, a tumor that's blocking the cerebrospinal fluid and it's building up and causing hydrocephalus, hematoma, blood is just pooling into that brain, an abscess where it's just pus just filling up, or a contusion where it's bruised, the actual brain tissue is swelling, you get edema, okay? All of this is going to lead to increased intracranial pressure. And when you get that, you're going to get decreased cerebral blood flow. And then you get decreased cerebral perfusion, all right? And then that brain is lacking that oxygen. It's going to get ischemic, and it's eventually going to die. It's going to infarct. And then your body does this thing where it's like, oh, I need to help it. I need to make it better. It tries to compensate. So what does it do? It says, hey, we need to send more blood. Let's increase that force of contraction. We're going to try to, pump it there. That's why blood pressure, that systolic blood pressure goes up. And it's trying to send more blood to the brain. And what is that doing? It's making it worse. You're getting edema. All right? And then that edema is leading to more compression. And eventually, it just cannot go on anymore. And it's going to herniate. And then that's going to equal death. And this is so, so bad. Some collaborative care for ICP. Our goal is to reduce it, obviously. We really want to prevent that herniation. We want to treat the underlying cause. So ID it and treat the cause, whether it be a tumor or hematoma. Just because the earlier we can recognize and treat it, the better the outcome. All right. And adequate oxygenation. We want to keep that oxygen levels up and carbon dioxide down or within normal limits. And remember, when carbon dioxide is up or increased, it causes that vasodilation. So anything that is acidic will vasodilate, okay? And what does that do? Well, it's going to send more blood to the brain, and we're increasing that pressure even further. So that's why it's really important to monitor those arterial blood gases. They can be intubated on that mechanical ventilation if needed as well. Now, cranial surgeries can help reduce that ICP. They can do it by that tumor or hematoma removal. So they want to take away as much as they possibly can, which makes sense. That's probably the best course if they can remove as much without impairing the functioning of the brain. Craniotomy is where they remove a portion of the skull, or they can do it like through a burr hole, and this is really to prevent that herniation. So just for a moment, think to yourself, all right, when this happens, when they are actually moving a piece of your skull through a craniotomy, what are some of the risks? Well, I always like to say, what is the purpose of the skull? Well, it's to protect. And what are we protecting the brain from? Damage and infection. Okay, that's the biggest things. Infection and damage. The skull is there to protect the brain. Now we've removed a portion of it, and if they fall, they're going to damage their brain. And a lot of times they'll have to wear a helmet as protection. We'll have to instruct them when they sleep not to lay on that side, and we really want to watch for that cerebrospinal fluid leaking. That's really an early notification of meningitis, so we really want to prevent that, especially if it's bacterial. We know that's the deadly one. Ventricular shunts can assist with drainage of blood or pus. If it's CSF, remember how it builds in the ventricles of the brain? And they can put a shunt in there and they redirect that fluid away from those ventricles so it can reduce the hydrocephalus. So that's a good one. Stereotactic radiosurgery is just like pure science fiction for me. Honestly, it blows my mind that they can do this kind of stuff. It is computer guided to obtain a biopsy, to drain a hematoma, remove a small tumor, or they can even ablate some of the bleeds that are in the brain. Pretty neat if you ask me. Fluctuation of ICP depends on these factors. The person's body temperature. So remember, if too hot, that increases their metabolic need, it increases that ICP. So we really have to be careful with that, and shivering as well. Oxygenation status. So just remember that the brain needs oxygen and proper nutrients so the brain can do its job. The brain can alter the cerebral perfusion pressure by either vasoconstricting or vasodilating. And it always seems like any compensatory mechanism, if goes prolonged for too long, it does more harm than good. And really, particularly carbon dioxide is an issue with ICP, just because if there are higher levels, if someone has a head injury, they become bradyopnea or they start hypoventilating, they're just not getting adequate oxygen and they're really retaining that carbon dioxide. And as you know, that's very acidic. And that extra carbon dioxide, or they're going to be in that hypercapnia state, will cause vasodilation. And with vasodilation, you're going to have more blood that's going to the brain, and that's going to increase ICP. All right? And body positioning. If a patient is too flat, it's going to pool up, and that blood is going to pool into their brain. If they're too high up, it's going to decrease. So that really, they prefer like a 30-degree angle. Arterial and venous pressure, and we talked about that. Arterial's too wide, it's causing more blood. And if venous pressure is too low or too high, it's, compressing down. It's not going to allow it to return to the heart. Anything that increases intra-abdominal or thoracic pressure is going to increase ICP. Like if they're vomiting, bearing down. So we really want to get medications to prevent that. Stool softeners and whatnot. Prevent that Valsalva maneuver. Anything that increases their metabolic needs. If they're agitated, if they start having seizures, malnutrition, pain, being just in a high stimulus environment, And I kind of named off some interventions with it, but you can see these factors that cause fluctuations with ICP and just kind of get your brain going and think of what am I as the nurse going to do? What interventions based off these factors am I going to do? Okay. So know the signs, especially early signs of ICP. Why is it so important to know the early signs? Well, as we've seen before, that herniation, okay, that brain getting ischemic. Of course, herniation is the worst part that really pretty much equals death. But every attempt that the body makes to keep perfusion or sending oxygen to the brain is just making it worse. It's a loop. So we need to stop it before it clamps down to the brain stem, by that herniation. So that's why we really need to know these early signs. And the very earliest sign is a change in level of consciousness. And when I mean change of level of consciousness, I mean restlessness, confused, having trouble with everyday normal movements, They're unable to respond to those very basic questions. And you can start seeing them have that slurred speech, Headaches. So just think about that building pressure and how that's going to, affect them. Vomiting, especially projectile without nausea, just all of a sudden coming out. That pressure is pushing down on that center of the brain that controls vomiting. Seizures, okay. You can get a positive Babinski reflex, where they fan out the toes. And there's that weakness on one side of the body or deterioration of certain motor functions too. Okay. More signs that ICP is progressing. You're going to see vision changes. They might show that diplopia, which is a double vision. They could have swelling of the optic nerve or that papilledema. There could be differences in pupil sizes, or it can be decreased or increased. Doll eyes is kind of a bad sign. Normally when you turn somebody, their eyes will go in the opposite direction. However, if they don't move along and they're kind of staying fixed in a midline, that's an indication that the brainstem has some damage. And then you have the decorticate and the decerebrate positionings. Decorticate, I like to think of core of the body. So they bring their upper extremities to the core, and it's kind of an adduction, and they're flexed of the arms. They kind of curl their wrist, and they kind of make a C shape. The legs are rotated internally, the feet are flexed, and the decerebrate is extension posture, and that's really the worst of the two. There is adduction, but their wrists are extended out, their arms are extended out on pronation. And here's a visual of the posturing, which I kind of like. The decorticate, you see how there's that C, and they're at the core, and it moves in towards the cord, this spinal cord. And then look at the feet, they're kind of inwards. And that's problem with the cervical spine tract or the cerebral hemisphere. And then the worst position is the separate with all the E's, extensor. The arms even kind of look like E's. That's usually a problem with the midbrains or the pons. Let's talk about Cushing's triad. And this is a late sign. And it's composed of 3 different things. And one of them is increased systolic blood pressure. And remember, the body is prioritizing getting oxygenated blood to the brain, but it's really only making ICP worse. And that's why you'd see a widening pulse pressure, that increased systolic blood pressure, and the decrease in diastolic. All right, you're going to see it widen. That heart is squeezing more, and it's squeezing harder to get more blood to the brain. And then you're going to see a decrease in heart rate. The baroreceptor reflex causes the heart rate to drop with the intention to decrease blood pressure, just kind of like your medications, your beta blockers. Swelling in the brain can compress down on that vagus nerve, which causes the decrease in heart rate too. And then you're going to see irregular, decreased breathing. And it could be like that Shane Stokes breathing where you have that periods of hyperventilation and then apnea where there's no breathing. And again, that is that increased intracranial pressure is causing part of that brain to clamp down on the medulla, brainstem. That is very vital to controlling breathing. And over here you can see here increased systolic blood pressure, decreased pulse, decreased respirations, and it's just the opposite of shock. Our goal is to prevent furthering the increased intracranial pressure, and we do that with our nursing interventions. A lot of times we want to do frequent monitoring of neuro checks. We want to check their level of consciousness. Are they getting restless? Are they, not responding? That Glasgow Coma Scale is a really easy one. It's quick to do. You remember 15 is considered normal. Anything below 8 is basically a coma, and 3 is absolutely the lowest. Vital signs, then, including that Cushing's triad, you really want to be careful with that too. So that's usually a late one. So if you're seeing that systolic blood pressure rise, you want to keep an eye on that. Fluid and electrolytes, especially sodium. Remember the complications are that irregular or dysregulation of ADH, either through diabetes insipidus or that SIADH. Okay. So, and also another thing, watch out for the temperature as well, because that increases that, metabolic needs, and it's going to increase that cranial pressure. So you want to be careful of that. Okay. And there are many reasons for increase in temperature. Damage to the hypothalamus, infection, dehydration. So if the patient is unconscious, just remember, don't take their temperature orally or in the axilla. I didn't put the temperature on here, but that is an intervention you want to check as well. Positioning of the patient is huge. So we want to keep the head of the bed to 30 degrees. This will help blood return to the heart. If the neck is flexed, it will decrease venous blood flow back to the heart. And we want to keep that neck straight, okay? And it helps to facilitate that blood flow away from the brain and back to the heart. And if the hips are flexed, this can increase the intra-abdominal and thoracic pressure. So remember, we do not want to increase that. We don't want them to bear down. We don't want them to do that Valsalva maneuver or even vomiting for that matter. That's why you're going to see stool softeners, okay? We turn them slowly every 2 hours as well. And then when you think about minimizing suctioning if they are ventilated, we want to manage their oxygenated status. So we think about carbon dioxide and how that causes vasodilation. The body thinks it's helping. It's like, I want to send more oxygen. And all it's doing is sending more blood to the brain, building up that pressure even more, okay? So why would we not want to routinely suction the patient? With that being said, it's because it decreases their oxygen levels. And if we do need to suction, because we have to maintain a patent airway at all times, so we only do it as needed. And of course, it's limited under, I want to say 15 seconds, even 10 seconds. And we really want to hyperoxygenate them prior. Okay. And then a low stimuli environment. So we want to avoid clustering activities all at once. We want to reduce that stimuli. Have low lighting, a calm environment, just because too much stimulus can increase that cranial pressure. And seizure precautions. We know that, we can give prophylactic medication for that. We want to, implement a padded rails, have a functioning suctioning kit with a yonker nearby. And we want to balance their medication especially pain, and those sedatives. We want to reduce them, of course, but we don't want to mask anything either. And if we're measuring their cerebral pressure, that's usually an intensive care unit. All right. Collaborative care for increased ICP. Some of the drug therapy's goals is to reduce that metabolic demands from agitation, inflammation, edema, and seizures that increase ICP. Once we get to like the complications, like the imbalance of ADH or the SIADH or DI, it becomes really hard to manage that patient on top of the ICP. Even worse is the herniation. So we want to prevent all of those things. And we can give patients a diuretic called mannitol. And remember, it's that concentrated type of sugar. It works in two ways. It can thin out the blood and make it less viscous. And second, it can increase that cerebral blood flow, which can increase brain's oxygen delivery. That's a good thing. So it, expands the plasma, and it has that osmotic effect by moving fluid out of those brain cells or those tissues and into the blood cells, those blood vessels. So we really need to monitor their fluid and electrolyte status when we're on that, okay? And just remember that drug enters the blood. It's very concentrated. It draws water that is pooling in the brain back into the blood. And again, we're going to be looking for fluid overload, that water intoxication and depletion, okay? And fluid volume overload or excess, signs and symptoms, heart failure like symptoms, pulmonary edema, urinary output, electrolytes. Patient might report a dry mouth, they might be thirsty, okay? We're going to see retention of urine. That's why we want to look for those urinary output. And if they have retention of urine, they're probably going to be hyponatremic. So remember, they're going to have that fluid volume overload. It's going to dilute it. All right. And when we give a hypertonic saline, remember that moves water out of the brain cells as well and into the blood vessels. And we must frequently monitor their blood pressure and their serum sodium levels, because fluid volume excess can occur with these as well, So you will probably see that hyponatremia. And just remember that either one of these can be given over the other, especially in an emergency situation. Like that ICP pressure remains at 23 or 24. Remember, normal is between 5 and 15. Anything over 20, we have to act. So we can give them whatever's available, whether it be mannitol or that hypertonic saline, okay? And we're not going to give them as a slow drip. We're going to give that fast, because there's just no evidence that one works better than the other. The patient can also get both at the same time, all right? So just remember, we want to monitor their blood pressure and sodium with that, okay? Corticosteroids can be given as well, like Decadron or dexamethasone. It inhibits that inflammatory mediators. Typically for brain tumors or abscesses, they're more ideal. Not really recommended for the traumatic brain injury patients. So we want to monitor their fluid intake, their serum sodium, and glucose levels. And any GI prophylaxis at protonics, we want to give that to them because of the side effects. But the biggest things about steroids that we all know is, the big one is hyperglycemia, immunosuppressant type properties. It can cause hypokalemia, increased sodium, and so we really got to be careful. It can delay healing as well, and we have to have them tapered down. Those are some of the big things to take away from steroid use, okay? So more drug therapy that we can provide. And just think about the metabolic demands that increases intracranial pressure. So agitation, shivering, and seizures, okay? And pretty much these medications can help with the prevention or reducing of the ICP. And we can start them prophylactically on an anti-seizure medication like Dilantin. We want to control that fever with an antipyretic, like acetaminophen, or use those cooling measures like, putting some cooling packs on their body. We can wrap their arms and legs with warm compresses to prevent shivering because, again, shivering, increases those metabolic demands and increases intracranial pressure. Sedatives, we really need to be careful when we're giving those. We do want to manage their shivering. That can help with it too, and their agitation, mainly their agitation. But because we don't want to over-sedate them, because we don't want to mask any symptoms of their deterioration, We want to give medications or these sedatives that have a shorter half-life. And the whole purpose is because, yes, we want to reduce that agitation. The agitation causes increased metabolic need, which increases ICP. But we have to do frequent neuro assessments on these patients, so we can evaluate them and say, hey, are they deteriorating or not? We don't want to assume that they are sleepy from the sedatives, okay? So sometimes we might have to do like a sedation vacation with them. And again, analgesics, why do you think we're giving that? Well, we want to control pain, obviously, but pain increases metabolic needs too, okay? And barbiturates like phenobarbital is used in increased cranial pressure. It's like a refractory to other treatments. It decreases that cerebral metabolism, which is a good thing, so it doesn't have the needs that, increases that intracranial pressure. So they're going to cause a decrease in ICP and actually a reduction in cerebral edema. Some more collaborative care would be nutritional therapy. We really need to meet the needs, their nutritional needs. Just because malnutrition promotes and continues to increase that ICP, causes cerebral edema. So we really want to maintain optimal nutrition with these patients. Increased ICP causes patients to go into like a hypermetabolic state. The brain has an increased need for glucose. It needs some type of energy source. So think about that. So we really need to either get enteral or that total parental nutrition initiated. And our goal is early, within 3 days of an injury, just because it is shown that that's the best outcome if we start within 3 days of their injury and we reach their full nutritional potential by day 7. Okay? And we want to keep the patient at a normal volemic fluid state. So that's why we want to do like strict I's and O's and measure that serum osmolality and even their electrolytes. Okay? And the preferred solution is that normal saline, just to prevent that osmolar shift. Of course, if they go into those complications like the SIADH and DI, we're not going to do that. We're probably going to give them like a hypertonic. Okay?